Hey everyone, and welcome! If you're a nursing student about to dive into Chapter 42 on fluid and electrolytes, you are in the perfect spot. Today, we're going to take that big list of 42 key terms and make sense of it all. The goal is to turn it from just a bunch of vocabulary words into concepts that actually connect, giving you a really solid foundation for class. Okay, let's get into it.
So here's our game plan. We're going to start with the absolute basics of body fluid, and then we'll look at how it all moves around. From there, we'll tackle the major electrolytes, then get into the kind of tricky world of acid-base balance. And finally, we'll tie it all together with what you'll actually see in clinical practice. See, it's a logical story, not just a list.
All right, first up, the fundamentals. Before we can even begin to talk about imbalances, we have to know where all this fluid in our bodies actually is. If you look at this, it's actually pretty simple. All the fluid in our body is in one of two main places. About 2/3 of it is what we call intracellular fluid, or ICF. That's all the fluid that's inside our trillions of cells. The other 1/3 is extracellular fluid, or ECF, which is, you guessed it, all the fluid outside the cells.
Now, we can break down that extracellular fluid just a little bit more. Most of it is interstitial fluid. That's the fluid that's kind of bathing the outside of our cells, filling in the gaps. The rest of it is intravascular fluid, which is just the fancy term for the liquid part of your blood, the plasma, that's flowing through your arteries and veins. So really, fluid is either inside cells, between cells, or in your blood vessels. That's it.
Okay, so now we know where all the fluid is. But how does it move between all these different spots? Well, that's what this next section is all about. It's this constant push and pull that keeps everything in balance.
There are really two main ways water gets around in the body. The first one is osmosis. The easiest way to remember this one? Just think water follows salt. Water will always move from an area with less stuff dissolved in it to an area with more stuff, trying to dilute it and even things out. The second way is filtration, which is basically just fluid getting pushed through a membrane because of pressure, kind of like water going through a coffee filter. And this slide shows the actual forces that make that happen. You have osmotic pressure, which is the pulling force. It's created by solutes, like sodium or big proteins, that literally pull water towards them. You'll also hear this called oncotic pressure when we're talking specifically about proteins. And working against that is hydrostatic pressure. That's the pushing force. Just think of your blood pressure pushing fluid out of the blood vessels. This constant push and pull is what keeps fluid moving where it needs to go. Now, let's build on that. We've got the fluid, we've got the forces, and now it's time to talk about the stuff dissolved in that fluid, the electrolytes. In this part, we're going to quickly run through the imbalances you'll see again and again with your patients.
Let's start with the king of fluid balance, sodium. Remember, water follows salt. So, too much sodium is called hypernatremia, and you can think of that as a water deficit. Too little sodium is hyponatremia, which usually means there's too much water on board, diluting everything.
Next up is potassium, and this one is so important for nerve and muscle function, especially for the heart. Too much potassium is hyperkalemia, and too little is hypokalemia. You've got to watch these levels closely, because either one can lead to some really dangerous heart rhythms. Then we've got calcium. We all know it's crucial for bones, right? But it's also a huge player in nerve impulses and muscle contraction. The terms are pretty straightforward. Too much is hypercalcemia, and too little is hypocalcemia. And let's not forget magnesium. It often works as a partner to other electrolytes, especially calcium and potassium. And again, the prefixes make it easy. High is hypermagnesemia and low is hypomagnesemia. All right, so we've covered fluids and electrolytes. Now we're at the third critical piece of the puzzle, acid-base balance. Our bodies have to keep their pH in an incredibly tight, narrow range to work properly. This table lays it all out perfectly. There are really only four main problems you can have. If the body is too acidic, it's called acidosis. If it's too basic or alkaline, it's alkalosis. Then you just have to figure out the cause. Is it respiratory, related to the lungs and CO2, or is it metabolic, related to the kidneys and bicarbonate? And that gives you our four terms: respiratory acidosis and alkalosis, and metabolic acidosis and alkalosis. So, how do we keep track of all this? Well, the body has these natural buffers that act like sponges to soak up excess acid or base and prevent big pH swings. Clinically, we measure a patient's status with a lab test called arterial blood gases, or ABGs. And for metabolic acidosis, we can even do a little calculation called the anion gap to help us figure out the cause. All right, in our final section, let's connect all these ideas to the real world.
This is all about the tools you'll use and the patient conditions you'll be managing when you're on the floor.
When we give patients IV fluids, they usually fall into one of two buckets. First, you have crystalloids, like normal saline. These have tiny little molecules that can easily slip out of the blood vessels and go into the tissues. Then you have colloids, like albumin. These have big, bulky molecules that act like sponges. They stay in the blood vessels and use that oncotic pressure we talked about earlier to pull more fluid in.
And the effect those fluids have really depends on their tonicity. An isotonic solution has the same concentration as our body fluids, so it doesn't really change the cell size. A hypotonic solution is more watery or dilute than our cells, so it causes water to rush in and make cells swell up. And a hypertonic solution is more concentrated, so it pulls water out of cells, making them shrink. It all comes back to osmosis.
Ultimately, all of this affects the patient's overall fluid status. If there's too little fluid in that extracellular space, we call it an extracellular volume deficit, or ECV deficit. You'll also hear it called hypovolemia. The opposite, too much fluid, is an extracellular volume excess, or ECV excess.
So why do we get these fluids in? We do it through venipuncture, which is the whole process of getting into a vein. We use something called a vascular access device, or VAD. That's just the umbrella term for any kind of IV catheter or port that we use to deliver the therapy.
But of course, it's not without risks. There are a few key complications you've got to watch for. Phlebitis is when the vein itself gets inflamed and irritated. Infiltration is when the IV fluid stops going into the vein and starts leaking out into the surrounding tissue. And then there's extravasation, which is a really serious type of infiltration where the drug that's leaking is a vesicant, meaning it actually damages the tissue.
And there you have it. A super fast review of 42 essential terms, all logically connected. We went from the basic fluid compartments to the forces that move it, to electrolytes, to pH balance, and finally to what it all looks like in practice. You've got the vocabulary now. The next step, and the real challenge, is putting it all together. So, I'll leave you with this question to take with you to class. How are you going to spot these imbalances in a real patient?